So thank you, sir. So respected teachers, senior ophthalmologist, my dear friends, I'm Dr. Nivean from Chennai, and I'm going to talk about Zonular dialysis management. So as you all know, to just make it simple and for learning thing, it can be graded into three grades. The mild, where you have up to 3 clock hours of zonular dialysis, or the moderate, when you have more or 3 to 6 clock hours of zonular dialysis, or up to 180 degrees, and then severe when it is more than 180 degrees or 270 degrees of subluxation. So why it's important is the things that you use like a CTR or a CTS, so or you go to fix the bag, the techniques might vary depending on the degree of dialysis. So there are some cardinal signs that you might notice sometimes intraoperatively that gives you a clue that the zonules are weak. Yes, when you have pseudo exfoliation, hard cataracts, there is always a risk of the zonules being weak. The second thing is when you're doing the rexes, sometimes you'll see wrinkling of the anterior capsule. So when there's a wrinkling of the anterior capsule when you're doing rexes, you know that the zonules are weak. And then during phacoemulsification, sometimes you notice that there is undue movement of the nucleus. There is something that is not the usual. So any of these signs should give you a reason that there could be some zonular weakness. And the third thing is sometimes you can see even the bulging of the iris. So sometimes during this zonular dialysis, the vitreous tends to prolapse to that area, and sometimes you see some irregular shallowing of the anterior chamber that happens at that area. So these are some of the, let's just go through a couple of case scenarios. The first one I'm going to show is a case of mild 3 clock hours zonular dialysis, which is very commonly seen in colobomatous eyes. So as you can see here, see these colobomatous eyes sometimes pose a challenge because the eyeballs are small and sometimes you get a harder cataract than expected. So getting the rexes for any of the cataract cases is very ideal. So make sure your rexes size is slightly smaller than 5.5. The reason being nowadays is in these types of cases, if you want to do an optic capture or you want to keep the lens in the sulcus, it is a great idea. So just make it 4.5 or 5 millimeter rexes. And then initial days, what I used to do is any of these complicated cases, I used to make a limbal incision like this, a 3-planar incision, rather than making a purely corneal incision, because you expect some complications, and sometimes when you want to convert, you don't want to extend the cornea and put sutures. So I prefer a limbal based incision in these cases. A slow, gentle hydrodissection, because you should see the wave. You don't have to be in a hurry. It's because these cases you have to treat it little differently from the routine cases. The choice of phaco is depending upon the surgeon's comfort. There is no literature saying that stop and chop is better or direct chop is better. The basic principle is you should have less stress on the zonules when you do these chopping maneuvers, and usually we do the phacoemulsification in the bag area, but in these cases I like to bring the nucleus slightly forward into the anterior chamber and then do again less stress on the zonules into the bag. The third thing is, even in these cases I treat them like a case when you have a rupture, that don't remove the phaco probe, because when you have this ZD, when the AC collapses, that is when the hyaloid tends to break sometimes and the vitreous tends to prolapse. So always make sure that the anterior chamber is well formed, keep it viscoelastic. And then the cortex, yes, the third thing I call this as a cortical stripping. So again what happens is you engage those anterior cortical fibers in the aspiration cannula, strip it to the center, and then once it comes to the center, then you aspirate. So basically again I am not pulling, because I have had cases where you think you have done the phaco and everything is over, but at last when you are doing the IA you pull more of the bag and then the whole scenario changes. So in this case, as I said, first we just showing how the placement of the CTR. So relatively simple. It is just that you should make sure and keep watching that the leading haptic goes into the bag, because we know once it slips outside it is very difficult. Sir, welcome. Very difficult to get it again. So keep an eye always on this. In this particular technique I use the dialer to put it in the inlet hole, and again make sure it goes into the capsular bag and then release the hand. You can also use the forceps, which I am going to show in your subsequent videos. So once you have, in these cases, I think a single piece foldable lens can be done well into the bag. And the last thing is, again, we like to place the haptics where you have those weak areas. So that again acts and stretches the bag and prevents further contracture and phimosis of the bag. And this was a small defect, so we did not repair the iris. So moving on to the second this thing where you have a more larger ZD, and we'll also show you how you can use this thing. There was another paper published by the Agarwal group about how vitrectomy assists in phacoemulsification in these kinds of ZD cases. The basic principle is, when we are doing phacoemulsification, there is this weak area of the ZD. So sometimes this hydration fluid goes back and hydrates the vitreous. So that is when sometimes in these cases suddenly you see there is some shallowing of the anterior chamber, because there is vitreous thrust that is pushing up. and then everything starts becoming difficult. So what they have proposed is a mild vitrectomy that can be done to decompress this vitreous in cases when you have a large ZD, when you know when you're doing phaco, there is going to be some amount of fluid that goes back into the eye. So here we have used the iris hooks to have a good visualization. This also helps you to know the extent of the ZD, because sometimes you see a ZD on a slit lamp and that is totally different from what you see on table. So in any case of doubts, use the hooks. Again, centration, as you can see those folds, because wherever there is no zonules, there is no counter traction. So that is the reason why doing a rexis is also challenging in these cases. So just stabilizing the bag by using a capsular hook, and again a gentle hydrodissection just to loosen out the nucleus. So this is the trocar. I think even anterior segment surgeons can start doing the trocar assisted vitrectomy. There are a lot of wet labs, and we have the man who's actually initiated the wet labs, Dr. Santanshu sir. So we have a lot of wet labs to show you how a trocar can be done, and anterior vitrectomy can be done through the pars plana approach. So basically it compresses the vitreous. So this is not only for colobomatous cases, wherever you see there's mild vitreous prolapse or there is a gap where in these ZD cases. So once you do that, phaco becomes very nice. You have a nice chamber. The only thing again is you should make sure your bottle height is lowered, and because sometimes it can, what you see in these myopic eyes, it suddenly shallows, and that can also cause a rupture. So first case bimanual, this case coaxial, but the principles of the IA will still remain the same. So now you have a nice good rexis, and you can see now we're going to place the CTR again. So in this particular thing, just showing how we can use the forceps. So bimanually you can guide it and make sure this time it did not go. So again re-grasp it and make sure it goes into the bag. So again inflate the bag, and 3-piece lenses in this is ideal because later on if some dislocation happens, so that was the theory behind that, so you can always refix these 3-piece lenses. But the newer teaching nowadays is you can also do an optic capture that is more stable in these types of cases where you have a weak bag. So in this particular case, as you can see, the iris defect of the coloboma compared to the first case was larger. So in this particular case, we did the single pass 4th row pupilloplasty also to reconstruct the iris. So it's a relatively simple procedure. As you can see, cosmetically also it is patient better, but also when you have a smaller pupil, it also decreases the corneal aberrations that is caused and improves the visual acuity. So moving on to the next, the use of the CTS segments. So far we finished 2 scenarios where we use the CTR. So CTS segments, yes, as you can see, there is always a debate when to place the CTR. So sometimes you will have to take the judgment whether you want to place it in the initial stages, or sometimes you want to do it in the after doing the removal of the nucleus. The only difference is they say sometimes aspiration of the cortex is difficult, but I think with practice the only trick I could say is, instead of pulling the cortex, you do a sweeping movement, so that makes it easier to remove the cortex. So you just make a scleral flap, or you can make a groove or a Hoffman's pocket. So wherever the area behind the zonular dialysis, so we're just passing this particular case we use the 90 proline sutures, the double arm sutures. So the second thing is threaded through the eyelets of the CTS segment. So there are various methods and various things, but this was a very simple technique where you just thread it into the eyelet of the CTS, and then it is railroaded and brought outside. So you have now both the ends of the sutures outside. So now gently place it inside and position it into the bag where the area of weakness is. Again, the only trick is make sure that the eyelet is always kept above the anterior capsular margin when you tighten it, nor it should not tilt down. So that can sometimes even cause a rupture of the anterior capsule. So just position it and then tighten it. So we have the CTR and the CTS and a well stable IOL. So the different grades, and the last thing is when you don't have the entire thing is subluxated, so we are left with only one option to remove the lens and place a secondary IOL lens. So in this particular case, we make a 180-degree flaps on either side. So we were planning to do a lensectomy, vitrectomy with a secondary CMT flex IOL. So basically we make 2.5 flaps on either side, and 1.5 millimeters away from the limbus we make a 23 gauge sclerostomy. I'll just run through the video fast. So in this particular case we use the same sclerostomies to do the lensectomy. Since it was a soft cataract, it was easier to do the lensectomy, just making a puncture posteriorly and with good aspiration and cut rate. So this is a new single piece hydrophilic CMT flex IOL with specialized T-shaped haptics on either side. So basically the idea was when you remove these haptics through the sclerostomy, it opens up and just stays in this thing. So there's no need for tucking or suturing of these lenses. And since it is can be done through a regular cartridge through any clear corneal incision, so you just hold the T part of the lens and then inject the remaining of the lens. At this time you should not pull it because it's a single piece lens, so it can detach from the optics. So just wait and inject and leave the trailing haptic either over the iris or at the wound. So once the injection of the lens is done, you just bring it outside. You can see the pop of the T and it opens up and that stays like that. So the same thing is done on the other side using the handshake technique. Yeah, the same thing is done on the other side using the handshake technique, and it is brought out. And once it is out, because of the 180-degree marking, there is not going to be any tilt or anything, and that is literally the end of the surgery, as you can see here. So thank you.
Thank you, thank you. So this lens has been real. Now invite Dr. Ajendra Prasad. This lens has been innovated by him, and this is very. I am also using this lens. This is really very helpful in emergency guide.